Afternoon, is everybody here?
Yes, Doctor.
None of you. Okay, everybody, camera on. It's going to be interactive. So who's the one presenting?
It's me, Doctor. I will be presenting today.
In your previous postings, did you guys manage to even get history from patients? Do you manage to clock any patients at all? No.
We managed to clock for IM posting, but for this posting, we haven't yet the opportunity to clock any patient.
What do you mean? Can you guys like say internal medicine? IM is syndrome of Coulter. Internal medicine. IM. You know, don't simply use abbreviations when it's not an internationally recognized abbreviation. So when you did internal medicine, did you guys manage to even clock? Yes? Less than 10, more than 10?
Yes,
Less than
Doctor.
10?
Yes, less than 10.
More than 10.
Physical examination? Managed to touch any of them? No?
Yes, Doctor. We are able to do all the physical examinations.
Okay, never mind. Iza?
Okay.
Start, Iza.
Good afternoon, everyone. So today we will start regarding the case discussion and presented by me, which is and I'm Nori Zahira Bibi Zamra with matric number 81819230. So this is the rough outline for today's case discussion. The first one is the story, and we'll start with the chief complaint. So Armel, 1 year 8 months old Malay boy with no underlying medical conditions, presented to the emergency department with the complaint of unresolved fever for 4 days duration associated with poor oral intake.
Okay, Iza, stop. Okay, Adik, what would you like to know? Adik, what would you like to know?
I would like to know if there are any other symptoms as well, aside from the fever.
Okay, wait. Now this is the presenting complaint, isn't it? It's fever with 4 days, 4 day history of fever with poor oral intake, right? So before you want to go into associated symptoms, what's the main complaint now? Fever, right?
Yes, fever.
Okay, so what about the fever you want to know?
Or is it high temperature? I mean, is it high grade fever, or is it low grade fever?
Zakwan? What else would you ask? High grade, low grade? Okay, fine. What else would you ask?
I want to know that if the parents have done something for the patient's fever, for example, such as giving medication such as PCM. I went to clinic.
Apart from PCM, anything else?
Went to GP. Went to GP.
Okay, whether the child was given any antipyretics, whether the child seek medical attention before coming to the casualty. Putri Sophia.
Whether the fever was intermittent or continuous. Was it on and
Okay,
off or
so
continuous?
the pattern of fever, isn't it? Right? You guys know certain fevers have certain pattern, right? Right, dengue fever, malaria, all those have pattern. What else has patterns? What other fevers have patterns? Anybody? So pattern of fever, fine. What else, Sophia?
Whether it is worsen at night or in the morning.
That goes under the whole pattern thing, isn't it? Right? Whether worse in the daytime, worse at night, whether it goes off in the evening, whether it's like 2 days once, 2 days once, 2 days once, or 3 days once in if you have prolonged fever and malaria, isn't it? Right? Whether going back to Zakwan, whether it's resolved with antipyretics or not, right? If this is a short duration, it's 4 days, but if it's a prolonged fever, then if the fever doesn't resolve with antipyretics, it might not be an infective cause, isn't it? Right? Okay, Nick. What else would you ask? So we have high grade, low grade, pattern of fever, and whether the child seek medical attention given any antipyretics.
I want to know whether the condition, whether the child is previously healthy or not.
Fine. You want to see whether this is an acute thing or whether the child is generally unwell before having this spike of fever. Fair enough. Afika.
Which Afika, doctor? We have two
Kan siapa kat
Afika.
belakang tu? Senyum-senyum dengan siapa kat belakang tu? Zakuan. Asyik
Sorry,
tenang ke kiri je tu.
sorry tadi ada kawan datang kat bawah.
Nak join tak? Kalau nak join suruh dia join sekali.
Tak. Dia dah suruh dia keluar dah. Sorry.
Fikah kan tadi? Afika, ha?
Afika Atira. Atira or Dr. Afika? We have two Afika actually, doctor.
Oh, sorry. Nora Fika. Atira nak jawab dulu. Atira jawab dulu.
Any sick contacts at home or nursery if the child went to nursery.
Okay, fair enough. Afika, Nora Fika.
Any like family members have the same symptoms?
Atira baru je cakap kan. Sick contact.
Sick contact.
Apa lagi?
Lagi. Any history of traveling?
Okay, fair enough. So, history of traveling, muddy places, right? But that being said, lacto tend to be a bit more prolonged, isn't it? Right? Atika, Gani.
Whether the fever is associated with chest and rigor.
Okay, associated, fine. We're reaching towards the end already. Udina?
I want to know regarding the severity of the fever, like does it affect this child daily physical activities?
Sorry, physical apa?
Does it affect this patient like physically activities, like does the patient able to do like normal thing, like he able
So
to
basically, level of activity of the child, isn't it? How is the child affected by the fever? Whether the child is active or not? Whether the child just maybe lies down? But that goes towards fever. So okay, fine. Iza, continue.
So for the fever, the patient was apparently well up until 4 days ago, where he started to develop fever with recorded temperature of 38 degrees Celsius by his mother. The fever was on and off and only occurred during the night. He was then given paracetamol at home, but the fever did not subside. The fever was associated with runny nose with clear and watery discharge. His father denied any incidents of watery eyes. Armel was then, on the same day, taken to Klinik Kesihatan Bukit Go for his regular checkups, but he was still febrile at that time. He was given suppository antipyretic, but the fever persists. So this is the symptoms of the patient. The first one is the vomiting. On the second day of illness, he had one episode of vomiting in the morning. The vomitus was yellowish white in color and is of milk content. There was no blood noted and it was non-bilious. He also, the parents also noted a poor oral intake. For example, the patient usually tolerates 200 milliliter of formula milk daily, 3 to 4 times daily, and is reduced to 200 ml once daily. And the patient also unable to tolerate any Polish intake. There are also signs of dehydration, such as decreased urine output. His mother noticed when changing his diapers at the usual time daily, it was dry. She usually changed diapers 3 to 4 times per day, but currently reduced to 2 times per day. And the urine was also concentrated with foul smell. The father also noted that there was reduced amount of tears and the child became less active. The stool also was hard and associated with blood. The parents said that the blood would come first before the stool. So on further history, there was no previous history of upper respiratory tract infection, and there was.
Go back to the previous slide. Okay. Second day of illness, had one episode of vomiting in the morning. Vomitus was yellowish white in color, milk content, no blood. Now, before that, you already know that there's upper respiratory tract symptoms, right? Runny nose, watery discharge, right? Any mention about cough or not?
No, no cough.
The person, would you like to know whether there's cough?
Yes.
It goes together, right? Upper respiratory or lower respiratory symptoms. If you have runny nose, obviously runny nose is usually upper respiratory tract. But then it doesn't mean that the child cannot be coughing, true or not? Right? So where's the history of cough? Okay, then what else? Vomitus. Whenever a child is vomiting and then has, okay, fine, because they didn't ask, you don't know whether the child is coughing, you wouldn't know whether the vomiting is post-tussive or not, right? So the other things that you need to ask. The other thing is, so the child only vomited once on day 2, is it? After that?
There was no any other episodes noted or stated.
Yeah, but it's not written here, isn't it? Right? So be very clear, because if the child is vomiting, if it's just one episode over the 4 days, maybe you can chalk it off to it being just one off, child not feeling well, muntah sekali lah, right? Or the mother was trying to force him to drink more water and then he didn't like and then he muntah lah, right? But if the child is vomiting persistently over 4 days, your differentials would change, wouldn't it? Right? So vomiting what? Day 2, after that got vomit some more or not? It's something you need to know, isn't it? Right? Post-tussive or not, also you need to know. I know they wrote about stools at the bottom, but usually the tendency is if you're going to ask about vomiting, you ask about stools at the same time, right? Because if the child is persistently vomiting, but not passing stools at all, then you're going to be worried about what? Intestinal obstruction. A lot of times if you don't ask them together, you might forget, right? Don't assume just because, especially in cases of AGE, don't assume just because the child is vomiting, the child is also having diarrhea, right? And if the mother say macam biasa je, you need to clarify macam biasa tu macam mana? Kali terakhir dia buang air besar bila? Right? If yesterday buang air besar, fine. If dah 4 hari tak buang air besar, then maybe it's a problem, isn't it? Right? For intake, fine. How old's the child again? Sorry, I forgot.
1 year and 8 months.
1 year, 8 months. Stool was hard associated with blood. Now, when you have a history of so-called stool was hard and associated with blood, you kind of need to ask how long has the stool been hard, right? Is it a new thing? Right? Blood will come first before the stool. What type of blood? Because if you are talking about interception, right, so-called recurrent jelly stools, right? So it wouldn't be like fresh blood. So sometimes parents might say, macam ada darah, like what type of darah? Is it like old blood? Is it like that? Does the mother look? Does it look dry, right? Or is it like really fresh blood? And if there's really blood, how much blood? Right? Is it just a streak in the diapers, or is it like 2-3 tablespoons really fresh blood on the diaper? The other thing is if the stool has been hard for quite a while already, maybe that blood stain thing isn't something new, right? Chronic constipation might get anal fissures, right? The kid might be having a little bit of blood streaks in the stool. So whether this stool is hard associated with blood thing is something new. Next, Lisa.
Okay, so the next one, the further history. There was no history of prior upper respiratory infection and there was no rashes noted. Father denied of the family living in dengue-prone area and there was no history of recent fogging. There was history of travelling from Perak to Kuantan. However, the father denied any sick contact, eating outside food and rodent manifestation. There was history of saltwater contact last week when the family went to Tanjung Lumpur. No other family members have the same symptoms. His son was not in any daycare and was taken care by his wife at home. Patient is not circumcised yet. Okay, so for the systemic review, on general, patient has a fever, poor intake and loss of weight. There are the signs of dehydration.
Lisa, back up. Okay. Tadi everybody got a chance already, right? Adib again. Is this enough? What else would you like to know? Or do you see a gap in the history that you would like to fill in?
Should there be any history to rule out other common causes of fever, such as meningitis?
What would you ask for?
Neck stiffness, a history of neck stiffness, and history of photosensitivity for the child.
How would you elicit photosensitivity? A history of photosensitivity in a 1 year, 3-month-old child? What questions would you ask? I mean, these are questions you want to know, but you kind of need to know how to ask, isn't it? It's 1 year, 3 months old. How would you ask?
Can it be like is it common for the baby to have difficulties to open his eyes in the morning?
Now, the younger the child is, the harder it is for you to get to ask so-called history of meningism. Okay? Because the younger they are less ways in which they can express themselves, right? If they're not comfortable, cry. If the light is too bright, cry. If the neck is painful, cry. Basically, that's it, isn't it? Right?
Yes.
The most you can do is like maybe so-called neck stiffness is that when the mother tries to change him or tries to move him around, he seems resistant to any movement to do with the neck, right? So that's the most you can get if the child is about 1 year plus, right? Usually tend to get a history of the child being irritable, right? But once again, non-specific, isn't it? Right? Any child that's unwell is going to be irritable. But it's a general clue when you have a lot of it joined to a lot of that type of history joined together, then you get a sense that maybe it's a bit more serious, right? 1 year, 3 months, not really. Less than 1 year, sometimes you can feel about bowel share, isn't it? If you're thinking about meningitis, right? Okay. What other things, Zahid, Izzah? Any other thing in the history that you want to ask, or anything in the history that you think there's a gap that needs to be filled in?
Any history of abdominal pain?
Sorry, tak dengar.
Any history of abdominal pain?
Kuat sikit.
Any history of abdominal pain?
History of abdominal pain. So why?
Because for example, abdominal pain is one of the warning signs of dengue. And
Okay.
it can also suggest pyelonephritis.
Sorry, tak dengar.
Suggest pyelonephritis.
Okay, fine. The other thing pertaining to this patient, if you're going to ask for abdominal pain, is also because the child's having hard stools, isn't it? All right. If your differential, since the child has so-called bloody stools, if your differentials is interception, you ask whether the child strains during defecation. Okay. Abdominal pain, warning signs of dengue, fair enough. Okay. Next, Zakwan, anything in the gap in the history you want more info?
Maybe I will go for I will ask if the patient have lethargy.
I think they already, the previous slide already showed, right? Less active.
Oh.
Right. Yeah, the child becomes less active. Of course, you can have to qualify what do you mean by less active, right? Is the child still able to play a little? Or is the child like mainly sleeping all the time? Right? Sophia.
If there's any history of sore throat because for oral intake.
How are you going to get the history from a 1 year plus kid? You can't, can you?
Yeah.
Right. Right. They wouldn't even be able to tell you sakit kat mana. They wouldn't even be able to tell you, isn't it? Right? Nick, anything else?
I want to ask if there is any history of mucosal bleeding, which is one of the warning signs for dengue.
Sorry, what? Sorry, can you repeat?
I want to ask any history of mucosal bleeding, any gum bleeding, any bleeding tendencies, because it's
Okay, so
one of the warning signs of dengue.
Okay, you're swerving towards dengue, fair enough. Fika? Nora Fika.
History of dysuria or frequency to for urine.
Previous slide already say appears to have reduced urine output, right? And frequency and dysuria, once again, 1 year, 3 months old, difficult to say, difficult to elicit, right? Frequency only if the kid is toilet trained, right? Then the mother can see how many times the kid goes up and down, goes into the toilet. If the child is not toilet trained, the child is still wearing a diaper, you cannot even get circumstantial evidence of whether a child has frequency or not, right? Dysuria also, the most you can get is that the child cries when he tries to pee, but also 1 year, 3 months old, a bit iffy. Go. 1 year, 3 month old who is already unwell is going to be crying all the time. Atika, Gani.
I would like to know if the mother noticed any distended abdomen after birth.
Why?
Because first, I was afraid of intestinal obstruction. Other than that, maybe distended abdomen can be also due to the liver enlargement, which can be the warning signs of the dengue.
Why is everybody veering towards dengue? But fair enough. Anyway, this sort of thing, there's no wrong answer, you know. As long as you are able to qualify your answer, it's fair enough, right? Afika, Hatira, anything from here?
Is there any history of jaundice?
Why?
That is a non-specific symptoms for if you are afraid of UTI. So child can be presented with prolonged jaundice as well.
Prolonged jaundice, but the child is 1 year, 3 months.
Also maybe you mean jaundice is not possible?
Not
Because
possible for the reason that you're saying lah. You're saying UTI because children can present with prolonged jaundice, but that is for a neonate, right? One of the causes of prolonged jaundice in a neonate, that means a baby who was just born within 1 month of age, right? One of the presentation would be prolonged jaundice. That's why the prolonged jaundice workup for a baby who present with prolonged jaundice, that means jaundice after 14 days after delivery. One of the workup would be to look for any signs of urinary tract infection, right? But you wouldn't get jaundice in a simple UTI in somebody who is already more than 1 year old. So if you want to ask jaundice, fine, but why in this patient? If you decide to retract your answer, then give another answer.
Okay, maybe the to explore more on the bloody stool. Is there any episodes like I don't know how to ask regarding the constipation, also the dietary, has the child been reduced in eat less fiber?
Okay, that is part of it, but that you need to explore is if the parents say that actually the hard stools have been there for quite a while, right? Diet, you guys need to go into it lah. Okay, fine. Irina, last one.
I want to ask if the mother noticed if the patient is having any weight loss, because this patient is one episode of vomiting and then also have oral intake.
Sorry? Have
Regarding
what?
have oral intake.
Oral intake, but reduce oral intake, what? The previous slide already got.
Maybe I can I want to regarding just now in the history it doesn't state that whether the fever is associated with chills or rigor.
Didn't Nick, I think Nick mentioned it, right? Chills and rigor just now. Something else, Nabila? Udina or Nabila? Or both? Something else? Come on. Even if you look at the history that's presented there, there's questions you can ask. Going back, Afika, Atira, if you want to ask about jaundice, maybe in relation to leptospirosis lah. That's the only thing I can think of lah. Right? Irina, one more time. You look at this. There's obviously gaps in the history, isn't it? History of traveling to Bila. When was the history of traveling from Perak to Kuantan? Why? Are you asking about history of traveling? By the same token, right? Can you have a history of traveling from Perak to Kuantan but deny eating outside food? You see the gap in logic now. I'm just saying this is how when you write your case write-ups, right? I mean, when you take history, you take the everything, isn't it? Then you need to sit down and you look at it. Does this make sense? Right? Can you have a history from traveling from Perak to Kuantan but deny eating outside food? A bit unlikely, isn't it? Unless the mother really packed food for the whole day lah. The mother or the father packed food for the whole day lah, isn't it? There's a gap. There's a gap there, isn't it? That doesn't quite make sense. When was the history of traveling from Perak to Kuantan? If it was 2 weeks ago and the symptoms is acute only very, very sure it's only 4 days child previously well, would that history of traveling be significant? Unlikely, isn't it? All right, unless it's something which a bit unlikely lah. Unless you're taking into account incubation period lah. Like now lah, isn't it? Raya was when 2 weeks ago. Now you're seeing what's happening, isn't it? Isn't it? Right? But this, I assume this history was taken like 3 or 4 years ago, isn't it? 2 or 3 years ago lah. But now, yes lah, history of traveling to Kuantan 2 weeks ago, and then that's why you guys are at home lah. Right? Patient is not circumcised yet. Okay, next.
Doctor, may I ask you? This patient have a foul smelling urine. I want to ask how foul smelling is foul.
It's subjective, isn't it?
So how's it?
Subjective. The mother says it's foul, you just have to take it as foul lah. Things that are subjective, you cannot. No? So if the mother says it's foul, to her it's foul, then it's fine lah. So what you need to do is make sure it's not a urine infection, right? So take a urine FME later on, take a urine culture later on, right? It can also be foul smelling when it's heavily concentrated and the child is dehydrated, isn't it? That type of bau, that honey type of smell when the urine is concentrated, not necessarily smelly infected type of thing, isn't it? Right? So, but it's a subjective thing, whether something is smelly, not as subjective. So if the mother says it's smelly, then smelly lah. After all, it's a history, isn't it? Right? Okay, systemic review, everything should be here.
So for the systemic review, on general, patient has fever, poor oral intake and loss of weight. There are also signs of dehydration. On head and neck examination, there were no neck swelling, no neck stiffness, no ear or eye discharge, no rashes or nasally space. On cardiovascular examination, there was no dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and decreased effort tolerance. On respiratory examination, there was no coughing, no sputum, no hemoptysis, no neck sweat, no wheezing, and no sore throat. On gastrointestinal, there was no hematemesis, melena, or abdominal pain. On genitourinary, there was no dysuria, hematuria, polyuria.
Yeah. Bukan tadi ada blood dalam stool ke?
Yes, okay.
Then melena tu? Right, the person who did this. Continue.
On endocrine system, there were no neck swelling, excessive sweating or drinking. There were no heat or cold intolerance, and nervousness or irritability. On the hematological system, there were no purpura, epistaxis or gut bleeding. On musculoskeletal system, there was no muscle cramp, joint pain or joint stiffness. On neurological examination, there were no seizure, abnormal movement, and posture or any weakness in upper and lower limbs.
Review as third, yes, you need to go through everything, right? Just to make sure you don't miss anything. But later on, as you get better, then you should be able to get your history, not like a whole list like this, right? But for third year, you guys need to practice asking everything under the sun, basically. Okay, next.
So the past medical and surgical history, he was admitted to an ICU 1 year ago for 1 day duration for observation due to tachycardia, soundless crying, and blue circulation. There were no other history of hospitalization, and there was no surgical history. On drug history and allergy history, he has no known drug and food allergy. He is on paracetamol 110 milligrams 6 hourly and IV cefuroxime at the time of clerking.
Okay, Iza. So when you're taking history, right, from a third year point of view, usually you stop at the point where they present at the casualty. Okay, so that IV cefuroxime thing shouldn't be part of this, right? The previous slide, that IV cefuroxime thing shouldn't be part of this, right? Paracetamol, fine if she was, at home was taking it lah, right? But at this point, don't include things that are in the duration of the hospital stay, right? Your history should stop for acute cases. Most of the cases, your history should stop at presentation to the casualty, right? The only time when your history would include the duration of the hospitalization would be when the child has been in the hospital for like prolonged, right? Maybe the child has already been in the hospital for 2 weeks, right? And within those 2 weeks, there's a lot of new symptoms, a lot of things that have happened which would change your diagnosis, right? So in those kind of cases, you will start off by saying, this child was clocked on day 14 of admission, right? He initially presented 2 weeks ago with a 1 day history of blah, 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 right? Then subsequently he was admitted, and during these 2 weeks, blah, 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 this has happened, right? You get it? So that would be one of the few times when you actually include what happened in the hospital, right? So the child has been in the hospital for a long time. Or if there are new symptoms which pop up during the hospital stay. But once again, usually the child would have been in the hospital for quite a number of days, right? Another time where you would include history of hospitalization would be if this was an admission through the clinic, right? Maybe the child was admitted last month for prolonged fever, lots of investigations done, right? Now clinic appointment, so has been admitted for the clinic for further investigations, right? So in those type of cases, your history would start from the beginning, right? So this child was initially admitted was admitted from the clinic through the clinic for further investigation of her current symptoms, right? This child initially presented 3 months ago with then was admitted for 1 month. In that 1 month, these things were done, right? Then subsequently discharged with medication, we don't know what, and has now come to the clinic for this, right? Where these are her current symptoms, right? But most of the time, it is uncomplicated. If it's an acute condition, your history should stop at history of presenting complaint. So you shouldn't put in the cefuroxime thingy here. Understand or not? Right? Okay, next.
So next is the birth history. For antenatal history, it was his mother's second pregnancy. The patient mother had a history of miscarriage before at 2 weeks periods of amenorrhea. On intrapartum history, he was born by a spontaneous vertex delivery with birth weight of 2 kilograms. There were no
2 kilograms is very small. Are you sure you copied the right number? 2 kilograms is small for gestational age. The child would have been admitted for much longer than 1 day, right? Not so much NICU lah, but probably the special care nursery lah, right? Because 2 kilos is very, very small. So Iza, are you sure you copied the right number or not? Or was this slide like taken
it was written
as is and you just
plus.
Okay lah, fine, 2 kilo plus 2.7 is the lower border. 2.7 is the lower border for term baby, right? 2.7, sorry, 2.4. 2 kilos is very small, right? So if it's 2 plus, then you better put 2 plus lah. Mother probably cannot remember lah. Okay?
Okay.
Next.
So the postpartum history, he had uterine jaundice for 3 days duration and it resolved spontaneously. And he was admitted to NICU once, as stated before. For developmental history, the growth history is not dated, but developmental history, gross motor, the patient was able to walk and run alone. He started walking at 7 months old. On fine motor, he was able to do the pencil grabs, do circular scribbles, and imitate vertical line. On speech, he can speak about maximum 3 to 4 words, and he started speech at 8 months old. He was able to point at 6 body parts. On social history, patient responds upon calling his name and able to put on his shoes and imitate house chores.
Okay, you just stop here. Now, the thing about taking history is that when you take history, you must also double check it with your own knowledge, right? So if like the mother says started to walk at 7 months, is that likely or not?
Usually at 1 year.
Yeah, it shouldn't be it's usually not likely. Then you need to ask the mother, what does she mean by walk, right? Was the child just like able to stand whilst holding on to something, or able to take a few steps while holding on to something, right? Or was he really walking unsupported? Because when you say walking at 7 months, to me, walking at 7 means walking unsupported, like that, right? Maybe what the mother meant was that the child meniti at 7 months lah, which is likely, but on the early side also lah, isn't it? Right? Some kids, a lot of times the earliest we hear, so they walk at 9 months, isn't it? Right? So whenever you take history and something kind of doesn't tally with what you know, you need to clarify, right? Generally, what's the Adik, generally what's the milestone for walking?
1 year, doctor.
Okay, walking unsupported.
Unsupported. Yes. 1 year and a half.
What's the upper border of acceptable for walking unsupported? Unsupported. If you pass that age, then you're considered delayed.
1 year and 6 months.
Yeah, so 18 months, right? So a child should be able to walk unsupported by the age of 18 months. Generally, you kind of remember it as being 1 year, right? But the upper border of it will be 18 months, right? So the kid is like 1 year, 3 months old, so 15 months, right? Still haven't walked yet, but can cruise. That's still acceptable. That's still normal, within a normal range, right? But if the child is 1 year, 10 months old, still not walking unsupported, then there's a delay in the gross motor, right? So needs a referral, need to be checked up. Able to walk and run alone. Okay, Zakwan, at what age is the child expected to be able to run?
At 2 years old.
Yeah, so 2 years old, right? Walk and run alone. I mean,
1 year, 8 months.
maybe lah, 1 year, 3 months, right? Maybe can lah. So, Sophia, pincer grass, expected what age?
9 months old.
Yes, like that, right, pincer? Scribbling. When do children start to scribble? Nick, scribble. I know you're looking at the book.
A second, doctor. I forgot.
scribble like this. Sorry, water bottle. 18 months, and then straight line, circle, right? Cross, triangle. Learn it that way, right? Okay, triangle will be 6 years old already by then. 18 months start to scribble between there and 2 years old. That's when you start your straight line and then the circle. So again, a bit too early lah. But this is saying not the copy a circle. You understand not? Copy a circle roughly about 2 years old, right? That means you draw a circle, the kid will copy. Right? This is circular scribbles, meaning the child just main conting je. Understand not? So that's roughly about 18 months. Once again, a bit too early for this. Okay? Speech, maximum 3 to 4 words, start speech at 8 months. Start speech. Able to point to 6 body parts. Fine. Okay, fair enough. Okay, next, Isa.
The patient is actually 20 months old.
1 year, 8 months, sorry.
1 year.
Yeah, but I mean that's okay lah. I mean the bottom part is fixed, is correct for his age. It's only the gross motor part a bit too early, right? Pincer, you expect at 9 months already he should be doing pincer, right? Scribbling, that's within age, immediate vertical line, so it's within age, right? So the next thing, if you are testing him, you would try to see whether he can do the circle or not. Right? If he can copy a circle, that means he's slightly advanced now, which is good enough lah. But if he cannot, so it doesn't mean that he's delayed, right? Because it's within the age range. Next.
So for nutritional history, on exclusive breastfeeding, the patient was only of 1 month exclusive breastfeeding, as patient does not favor breast milk, even after the milk is pumped into a bottle. And so the patient started formula milk at 1 month old. Parents change the formula milk every 3 months, as patient does not gain weight, ideally based on the doctor's advice. He is currently on Pediasure for weight gain. Bottle was regularly boiled with hot water and washed with soap and water using a brush thoroughly. On weaning, he started at 7 months old. He was given puree and porridge during the time. He's not a picky eater and currently is taking adult diet, eating rice with soup, chicken and broccoli. Usually he is only able to finish 5 to 6 spoons. He drinks formula milk 200 ml 3 to 4 times daily.
Now, in view of the child having hard stools, right? So once again, because we don't know from the history, right? We don't know how long the hard stools has been going on, right? And then the other thing, because in view of the child having hard stools, just saying that the child is taking adult diet, eating rice with soup, chicken and broccoli is not enough. You actually have to try to quantify. Now, if the child was totally normal, growing totally normal, then that history is adequate, right? But if the child is small for age, later on when you do your physical examination and then you find out that the child is small for age, right? Or the child is obese, right? Or the child has problems with elimination, like this, have hard stools, then you need to go back and ask your history properly with regards to diet. Okay, so just saying that child eats broccoli is not enough. How much broccoli does he eat in a day? Right, with each meal. My daughter eats like 2 little pieces of broccoli with her rice. Obviously not enough fiber, isn't it? Right? Obviously the stool is going to be hard. So because you have a reason to ask about diet, you need to be a bit more detailed than this, right? So how much rice? Is it all rice, soup, bits of chicken, and then like 2 pieces of broccoli, right? Because you want to know how much fiber he's taking. What other vegetables does he eat? Does the child eat fruits or not, right? Does the child drink a lot of teh or not? You get constipated, right? And then some families, somehow they give young kids, they allow the young kids to drink tea, right? Some families lah. So this is not adequate, right? But like I said, if the child is totally normal, BOPU normal, when you plot the growth chart within the ranges, right, then you don't need to ask. But if the child is having problems like this one, having hard stools, you need to be a bit more detailed. This is not adequate, right? Same thing with if the child is obese. Just saying that a child eats 3 times a day is not adequate, right? If the child is obese, maybe came in for upper respiratory tract infection, right? Then when you plot the growth chart, the child's weight is like 90th centile, the child's height is only 10th centile. So obviously short and fat, right? So you need to go into how many times a day does he eat? At breakfast, how many bowls of rice does he eat, right? What type of food does he eat? Steamed chicken and fried chicken, calories are different, right? Fried chicken, obviously, calories much higher than steamed chicken, right? If he's eating fried chicken 3 times a day, obviously there's going to be an excess of calories, isn't it? Right? I'm not talking like small bits of fried chicken lah. I'm talking about like 2 big pieces of drumstick. Obviously, that's a bit too much, isn't it? Right? But some kids, right? If he's eating nasi lemak, not the nasi lemak bungkus, the small one that you get in the morning, right? You're eating the nasi lemak, the extra special one with the fried egg and the ayam masak merah one side plus the sambal, then obviously that calories is going to be very much more than your nasi lemak bungkus 150, isn't it? Right? So you need to ask properly. Snacks in between. Does a child snack in between? What does he snack in between? Fruits, or does he eat like the whole strip of Oreos at one go? Drinks also make a difference, right? Does the child only drink plain water, or does the child drink fruit juices, like only drinks fruit juice in between, right? Even if you fruit juice, fizzy drinks, right? Coca-Cola, 7-Up, all those things, the calories will add up if you drink it very often, right? So if the child is obese, you need to ask about all those things, right? How they cook, like I said, last steamed food, obviously less calorie in dense than fried stuff, right? Mee curry, obviously more caloric dense than mee soup, right? The mee curry that's full of santan lah. Even kueh also, if you keep on eating like one big bowl of cekodok pisang every afternoon, that's also like very high in calories, isn't it? Right? Then also there's the sugar lah. So if the child is on either end of the spectrum of being obese or too underweight, your history needs to be a bit more detailed. If the child comes in for a history of constipation, then the diet also needs to be a bit more detailed than this. Okay. Next.
Doctor?
Yeah.
Sorry, do we need to explore on the milk?
What do you mean by explore on the milk?
Because a certain formula milk can contribute to the dehydration, such as a dried skim milk, because it contains high mineral and protein, so it can cause dehydration.
Is that a problem with the patient now? Is there a problem with this patient?
Because patient
No.
shows a moderate signs, moderate dehydration, signs of moderate dehydration.
But your child wouldn't be dehydrated because you change milk.
What do you mean,
right?
doctor?
If milk causes some parents say the milk causes constipation, or some parents say when the child drinks milk and the child seems to have specific allergies towards certain components in the milk, right? It shouldn't cause the child to be dehydrated. Furthermore, this dehydration is an acute dehydration which seems associated with fever. If you are not sure, then you can just ask the mother whether the mother changed milk recently. That is all, right? But usually changing milk will not cause dehydration, not in this manner. Okay, next.
Okay, so he took immunization up to his age according to the immunization schedule by Kementerian Kesihatan Malaysia. For family history, he is the only child in the family. He is not a child of consanguineous marriage. His father is 24 years old, a soldier at grade, active smoker and smoked 2 pack years. He has no known medical illness. His mother is 25 years old, housewife, non-smoker and no known medical illness. Both deny any alcohol intake, drug abuse and sexual promiscuity. For social history, they live in Perak in Terrace Out with complete basic amenities. Currently, they came to Kuantan to visit their family. In Kuantan, they live in Felda Bukit Sagu in the kampung area with his grandparents. The house also has complete amenities such as water and electrical supply. House occupant has 7 people. Total household income is 1,800 monthly. Nearest primary care clinic is Clinic Kesihatan Bukit Go, about 15 minutes away from the house. There were no recent travel history except travel history from Perak to Kuantan. So physical examination. On general examination, patient was alert and conscious. The patient was yes.
It's always good, right, when you're first starting out to practice summarizing. So, Iza, can you summarize the history, please?
So the patient, 1 year, 8 months old, presented to emergency department of HTAA with complaints of fevers for days durations associated with poor oral intake, signs of dehydrations, 1 episode of vomiting, and constipation. He also noted, the patient also noted.
Can you repeat the
parents of Armel, 1 year 8 months old boy, presented to emergency department of HTAA with a complaints of fever, unresolved fever for these durations associated with poor oral intake, signs of dehydrations, polymery urine, and constipation.
I'm not sure whether it's my Wi-Fi or I can't hear. Is that clear to everybody else? Is that clear to everybody else? Yes.
A bit stuck, Doctor.
Yeah, because I can't hear you very well. You're stuck in between. Can you just try one more time?
Okay. My patient Armel, 1 year, 8 months old, presented to HTAA emergency department due to complaints of fevers for 4 days duration associated with poor oral intake, moderate dehydration, constipations, and polymery urine.
I would think that it would be, this patient is a 1 year 8 month old Malay boy who presented with a 4-day history of fever associated with upper respiratory tract symptoms. Upper respiratory tract symptoms, full stop. He also has history of hard stools with blood streak and full stop. And then that's enough, isn't it? Because it's a summer read, right? Okay, continue with physical examination.
Okay, continuing on the physical examination. The first one is the general examination. On general examination, the patient was alert and conscious. The patient was sitting comfortably on his bed. He is on medium build. He is not in pain or in distress. His nutritional status and hydration status were good. Granular attached at his right dorsum of hand, and there was band aid on his left wrist. There are no dysmorphic features noted. His size is appropriate with age. There were no pallor, jaundice, and cyanosis. There were no tremor noted. Capillary refill time was less than 2 seconds. Head and examinations, there are red flat rashes noted on his left lower cheek area. His tonsils are mildly injected. No central cyanosis. Oral hygiene is good. Other than that, there was no swelling or neck stiffness. JVP was not raised.
Okay, alert and conscious, sitting comfortably on his bed. I think with me, right, usually try not to use the word comfortable because you get so used to saying the word comfortable, because comfortable is very subjective, right? So like a child who has cyanotic congenital heart disease, right? So their saturation is not going to be more than 90%, isn't it? Right? When you look at them, they look comfortable. But by right, they're cyanotic, isn't it? True or not? So somebody, you use comfortable, it's very subjective. You need to say something that's very objective. So alert and conscious would be enough. The other thing about saying comfortable, you get so used to it. Sometimes some kids, like those with acute bronchiolitis, we are what we call happy wheezers, right? They are like happy playing away, but then they are also tachypnic at the same time. But because they're happy and playing away, you say they are comfortable. But when you count the respiratory rate, they're actually tachypnic. You know what I mean? No? So try not to use the word comfortable, because at some point you're going to see a patient who looks comfortable, but objectively when you count the respiratory rate or you assess the level of consciousness, they are not going to be so-called comfortable, right? And then you're going to just blurt out comfortable just because the patient just sitting like that, right? So try not to use the word comfortable. Alert and conscious is good enough. If you're going to talk about he is on medium build. He is medium build, right? So you're going to talk, if physical examination includes plotting the child on the growth chart, so the medium build and the size is appropriate for age should already go together, right? He's a medium build child. Because this is a long case presentation where you would already have your charts with you. You understand now? And he is on the 50th centile for his charts, right? Because this is a long case presentation. This is not a like short case. If short case, then fine. You can just say he appears appropriate for his build. He appears medium build lah, right? But appears appropriate for his size, appears appropriate for age. But I would like to plot his height and weight on a growth chart, right? But because this is a long case presentation where you would have already been expected to take out the growth chart and to plot the child's centiles on the growth chart, you would already immediately bump this together with he is medium build with a height on the 50th centile and a weight on the 30th centile. Full stop. You get what I mean? Right? This is a different situation from a short case where you just see the child and you agak-agak, does he look small, does he look big? Right? If this was a short case, then yes, you say he appears medium build, right? Or he appears more for age, but I would like to confirm this by plotting his centiles on the growth chart, right? But because this is a long case, you will already be expected to already fit in the growth charts here, right? Nutritional status and hydration status were good. Aside from this, I mean, why present tense then suddenly past tense? When you pass up any case write-up or whatever it is, make sure your tenses are consistent. If you decide to use present tense, then it's present tense all the way. If you decide to use past tense, then it's past tense all the way. Right? You guys see, right? He is medium build. He's not in pain. His nutritional status and hydration status were good. The tenses? English class now. Right?
Good.
Yeah, if you decide to use present tense, then present tense all the way. You decide to use past tense, then past tense all the way. I mean, if this was a write-up, I mean, nobody's gonna, is anybody gonna take away points? I mean, it's irritating, isn't it? If this was a write-up and you keep on, and the person reading your write-up keeps on coming across grammar mistakes, right? Just try to minimize it as much as possible. Right? I cannot be 100%, but try to minimize it as much as possible, isn't it? Just write off some of offhand. Also, and there was a bandit on his left first. Yeah. Okay, capillary refill time less than 2 seconds. Oh, this should go up with the hydration status, isn't it? All right. So what you can do is you need to learn how to group things together. So patient was alert and conscious. He is of medium build, right, with a height and a weight within the 50th centile of his growth chart. Full stop. Right? His nutritional status was good. His hydration status was also good. Where his capillary refill time was less than 2 seconds, he had redness membrane kind of thing, isn't it? The other thing is also you should start off with your vital signs, isn't it? Blood pressure, heart rate, temperature, right? Red flag rashes noted on his left lower cheek. Not enough, isn't it? Yeah, is this something to do with the disease or not? Right? Red flag rashes. What? Flat, fine. Flat, but how's the surface of the rash? Is it dry? Is it rough? How big is the rash? Right? Is there any similar rashes anywhere else, right? Flat rash. Rashes, rash. Is it like an abrasion or what? We wouldn't know from this, isn't it? Right? If it's a milk rash, but 1 year, 8 months old, a bit unlikely lah. Then you would expect bilaterally rough skin, drying, peeling, isn't it? Right? All right. JVP not raised 1 year, 8 months old. I doubt you can actually look at for the JVP. Neck short, right? 1 year, 8 months old. The neck will be very short. How to see JVP? Cannot, isn't it? Certain things with kids you have to adapt, like chest expansion. If the child is too small, you cannot get your hands around the torso. You cannot do chest expansion reliably, right? Certain things with kids you have to adapt. JVP also, if the neck is short, because they're young, right? Neck very short, right? Also you cannot check. Then why mention when you cannot check, right? Next.
So next is the vital signs and the anthropometric measurement. So for the vital sign, the blood pressure is 96/50 millimeter mercury, which is normal. Pulse rate is 100 beats per minute, which with good volume and relatively good rhythm. The respiratory rate is 28 breaths per minute, which is normal. The temperature is 37 degrees Celsius, and the pulse oximetry is 98%. For anthropometric measurement, the weight is 7.4 kilogram. The height is 76 centimeter, and the head circumference is 47 centimeter.
Okay. This doesn't, when you write the anthropometric measurements, make sure you look at the growth chart and you plot it on the growth chart, because this doesn't mean anything. Like pure numbers don't mean anything, right? You need to say whether the child's on the 50th centile or the 25th centile or the 2nd centile, because nobody can remember the exact number offhand, true or not? Right? So would you know whether this is normal? You wouldn't, isn't it? Right? So whenever you do anthropometric measurements, make sure you also mention the child centile on the growth chart. Okay? So which centile is the child on? 10 centile, 25th centile, 50th centile, 75th centile, or whatever centile it is. If the child is between centiles, then between the 50th and the 75th centile. Right? If the child is below the 3rd centile, then you have to say it's the equivalent of the 50th centile of what age? Like this. Yeah. Okay, let's say the child, now we're talking about very, very underweight child or very, very obese child. Okay? Now, your growth chart will curve like that, right? Right? Okay. Okay, just assume this is the 3rd and that's the 90th. Got it? This is under the 5th centile, right? Some charts are 3rd, some charts are 5th. It depends on which chart you use, right? This is under the 5th centile, right? This is also under the 5th centile, right? Understand or not? So if you have conditions like that, it would be very helpful if you could say the equivalent of the 50th centile for what age. So like, let's just say the child is 9. Okay. What you do is you find the 50th centile along this chart. You find out where the 50th centile is. So the blue line would be the 50th centile. You get it? Right? Because when you are presenting orally, right? We don't have the chart, right? Right? So it's very difficult for the person to imagine how small is small. Okay? So what you do is you look at the 50th centile, right? And then you track back and see if this at this weight, what age is it at the 50th centile? You got it now? Right? So you draw a line horizontally and until you cross the 50th centile, right? So let's just say this is the 50th centile of a 5-year-old, right? So let's just say the child, let's say you say the child's centile is less than the 5th centile for his age, equivalent to the 50th centile of a 5-year-old kid, 5-year-old boy, right? And then let's say this kid here who is smaller, right? The 2 dots, right? This kid smaller, right? Then you go again horizontally, and let's just say you get the 50th centile here is equivalent to a 3-year-old child. So when you present, you know that this child by size is smaller than this child. So in your brain, even if you don't compare, so if you say this child is 9 years old, his weight is less than the 3rd centile, which is equivalent to the 50th centile of a 3-year-old boy, then in your brain you can know, oh, he's 9 years old, but he's only like 3 years old, the size. Get what I mean? Same thing with if this boy, right? This boy, the first boy, he's 9 years old, his weight is less than the 5th centile, which is equivalent to the 50th centile of a 5-year-old. Then you know that, oh, okay, so he's around that age. In your brain, then you can imagine that he's around that age. You know what I mean? So the same goes for somebody above the 90th centile, right? So let's just, if it's here, so what you do is you go forwards horizontally, cut the 50th centile, right? And then maybe you get somebody who's 15. Okay? So you say, oh, this child is above the 90th centile. He's the 50th centile of a 15-year-old boy. Right? So you know, okay, that's a big boy. Right? Maybe you have another boy who is then 50th centile of a 12-year-old boy. Then you can think in your brain, okay, he's big, but not like too extremely big. Right? Same thing with the small kid lah. If he's equivalent to a He's 9 years old, he's equivalent to a 5-year-old at 50th centile, then you think, okay, quite small. But if it's equivalent to only a 2-year-old size, then in your brain, you know, oh, that's very, very bad. The child is very, very small, right? Because this is a presentation, you don't have a thing to look at. You get what I mean now?
Doctor, so every time we present the anthropometric measurement, then we, if the child is below third centile or above 90 centile, we need to also mention, for example, above 90 centile and at 50 centile of what age of boy.
Yeah,
Like
that would give a very good indication, right? Because everything above here, a boy or girl, depending on the patient, everything above here is 90th, isn't it? Everything under here is below 5th, isn't it? Right? So it gives you an idea of how small the child is and how big the child is. From a practical point of view.
But do we need to write in the case write-up?
Would it hurt you to write?
No, but I've never seen one before, so that's why I asked.
Yeah, because nobody taught you before. Would it hurt you to write? No, isn't it? And is it good practice to know?
Yes.
Is it good practice to know? It's good practice to know, isn't it? In the write-up, you don't need to write. You don't really need to write because you are supposed to put in your centile charts in it. Right? In a write-up, your centile charts are part of your report. Yes or no? It should be part of your report. If it's not part of your report, okay, but if it's a write-up, I would expect the centile charts to be in your write-up. If you are presenting, then it's just good practice to present it that way. So it gives the examiner or gives the person you're presenting to an idea of how small or how big the child is. All right. If you write it up, I don't think it's an issue because it's not wrong. And in fact, I don't know, maybe you, I'm not sure whether they give you more points, but I mean, it shows that you're thinking, doesn't it? Right? But like I said, in a write-up, I assume your growth charts are there. If the growth charts are not there, then I would prefer you to write it up. Then it shows that you're thinking. Right? But if you don't write it up, so nobody's going to penalize you for not writing it because it's not required yet. I'm not asking you to go for distinction, but I mean, in a practical sense don't you think it, when you present it that way, it gives you a better idea? Continue. Anyway, this person needs the growth chart there. Because 47 normal or not normal? Any idea? Head circumference 47 centimeters, normal, not normal? Unless the next slide is the growth chart. Is the next slide the growth chart?
It was not.
Is the next slide the growth chart?
No, doctor.
So if you don't have a growth chart included, please write down the centiles. Right? The bare minimum, which is what centile the child is on, or under what centile or above what centile. Right? Next.
So next is the abdominal examination. So an inspection, the abdomen was not distended and was symmetrically with respiration. There was no scars noted and no dilated vein seen. The umbilicus was centrally located and inverted. The hernia orifices was intact. On superficial palpation, the abdomen was soft and non-tender in all 9 quadrants. On the palpation, there were no hepatomegaly or splenomegaly. There were no other masses. Kidney was not vegetable. On percussion, shifting downwards and neutral was negative. On auscultation, normal bowel sounds were heard with no bruit detected. So for cardiological examination, on inspection, the chest moved symmetrically with respiration with no surgical pericardium scar, pericardial bulge, or visible pulsation. On palpation, the apex beat was palpable at 5th intercostal space in the mid-clavicular line and was normal in character. There were no trill or parasternal hip noted. On auscultation, both first and second heart sounds were heard. There were no additional heart sounds, and there were no murmur detected. For respiratory examination, again the chest moved symmetrically with respiration. There were no chest wall deformity, surgical scar, or usage of accessory respiratory muscle. On palpation, the trachea was centrally located and the chest expansion was symmetrical bilaterally. Tactile vocal formatus was equal bilaterally. Percussion notes were resonant and equal on both sides. Vascular breath was heard at both lungs. Air entry is good and there is no added sound. Vocal resonance was normal.
Stop. Then stop at respiratory. Now, this one, I know, right? The person who wrote this just wrote it for writing, just wrote it without thinking. 1 year, 8 months, right? Can do tactile vocal parameters not? Cannot. How are you gonna get the kid to say 99999? Cannot, right? Can do vocal resonance not?
No.
Cannot. 1 year, 8 months, right? 20 months, right? Vocal parameters, tactile parameters, if the child is cooperative, maybe 3 years plus cooperative child. Not cooperative, maybe 5 years plus. All right. 1 year, 8 months, haven't even talked properly yet. No way you can do it. All right. Chest moves symmetrically, respiration fine. In younger children, most of the chest expansion, whether the chest moves symmetrically or not, is by inspection, no palpation, because you cannot do chest expansion in a young child. Number one, because when you do chest expansion, you guys did medicine already, right? The reason for doing chest expansion is one, to see whether the expansion is adequate or not, right? That's one. The other thing is to see whether it's symmetrical or not, right? The right side moves more than left or left side moves than right. Okay. Now, if you have a child, wait. Okay. No. Now, be good. Okay, in order to do chest expansion, right? Number one, the child's chest must be big enough for you to get your arms around it, right? So if you get a baby whose torso is only this small, and the expansion is only this much, can you see a difference or not? Cannot, isn't it? Right? The other thing to do chest expansion is that you need a person who is cooperative, right? Because the person needs to breathe in and out, right? Now, this naughty boy here supposedly can follow instructions, right? Supposedly can follow instructions. You see whether he can or not? Wait. Relax. Relax. Okay, breathe in. Breathe in. Breathe out. Breathe in. You see how difficult it is? Okay, again one more time. No, properly. Okay, breathe. Yeah, okay, breathe in. Hold. Breathe out. Breathe in. Breathe out. Okay? Even with a supposedly cooperative child also, you see how difficult it is, right? So if you have a child who don't understand you, or the child who refuses to understand you, you're not going to be able to do chest expansion. Okay? If you have a child is too small, like that, you're not going to be able to do chest expansion also, because the differences in them breathing in and breathing out will be too little for you to see, right? Also, the differences between right and left also you cannot see because the chest volume is so small. So in these type of cases, in younger children, usually it's mainly by inspection, right? 5-year-olds, you can try. 5-year-olds should be able to follow instructions, right? 4-year-olds can lah if they are the obedient type, right? So breathe in, breathe out. So chest expansion, they need to breathe in, breathe out, breathe in, breathe out. If it's unequal, then one side will move more than the rest. If the child is 1 year old, 2 years old, you cannot do it because they don't understand you and because the chest cavity is too small anyway for you to see any difference, right? So if the child is less than 2 years old, I wouldn't even show that I'm doing the chest expansion because no point, right? If the child is 3 years old, quite a big child, seems to be able to understand you because you also need good effort, right? When you do internal medicine, those uncle auntie with COAD, you ask them to breathe in, breathe out, isn't it? Right? If 3 years old, chest wall big enough, but they like play around, cannot do, right? But if the child is more than, this is an arbitrary number, it's not set. If the child is like 4 years old, you can try. 5 years old, you can try. If the child is 7 years old, definitely you need to show lah, right? 4 years old, you try once or twice. If cannot, then just go on to percussion, right? The younger they are, the more important thing is for you to expose and to inspect properly. Okay. Chest expansion symmetrical bilaterally. Obviously, tactile focal. Okay, fine. The throat, they didn't examine yet, Lisa. What's the throat? And the ears? I mean, there's runny nose, right? So if you think it's upper respiratory tract, you still need to look in the throat, right? And the ears, right? Is it later or what? By right, it should be in the beginning, right?
It was mentioned mildly injected throat in the beginning in general examination, but other than that, there were no ear discharge or ear examination done.
Done. Yeah, examination done normal. Where was it?
It was not mentioned.
Not mentioned. Not mentioned. You cannot say that's not done. No. Next. Isa, next.
Neurological examination on upper limb examination, the muscle bulk are normal. There were no muscle wasting and abnormal posture. There is no fasciculation and involuntary movements. The temperature are normal on both sides. The muscle tone, power, and reflexes were normal. Lower limb examination, the muscle bulk are normal. There were no muscle wasting, abnormal posture. There is no fasciculation and involuntary movements. Pronus was negative. The sensation, cerebral, and cranial nerves were not able to be performed.
Okay, it's not true that the cranial nerves are not able to be performed. Cranial nerves in a very young child is mainly observation, right? You can say that the face is symmetrical, the child smiles symmetrically, right? Eye movement you can do, isn't it? Right? Just use whatever toy. I mean, by right, you're supposed to use that red ball in your kid, but then you can just use whatever toy they have, and then you can just roughly track whether there's any gross problems with eye movement, isn't it? Right? So that's already 6.3, right? When the child interacts with the mother, and the child is laughing, then you need to see whether it's symmetrical or not, isn't it? Right? Or if the child is irritable that day and then crying, when the child cries, is he able to close his eyes properly or not, right? So those are part of the cranial nerve examination. Right. So if you are going to put in your cranial nerve here for somebody this young, then you can see the child smiles symmetrically, able to close both eyes, right? When eye movements seem to be adequate for both eyes, right? There's certain things that you can test, right? When the child is when you're checking the throat, you can look at the uvula, can't you? Right? That's also part of it, right? Obviously, this cannot lah. But you can see whether the child can move the head from side to side. So that's cranial nerve in a very young child. Okay, next.
So for the summary, so
Okay, the other thing about abdomen is because one of the complaints was hard stools, right? So look very hard for whether any stools are palpable when you do an abdominal examination, right? And then mention it as a relevant negative. Also, because there's so-called blood-stained stools, also look at the anus, right? See whether any fissures, any excoriation that might explain the blood, because that's part of the complaints, isn't it? Because if you look at this, then how to explain the constipation and the blood-stained stools? Also, that being said, the history wasn't complete, isn't it? We don't know whether the hard stools has been ongoing or whether it's recent. Yeah. Foul smelling, urine, and vomiting. So you think it's UTI. What's the basis of moderate dehydration here, Isa? Capillary refill, less than 2 seconds. Heart rate seems normal. Then what was the heart rate just now? What's the heart rate just now? You know watching me? What's the heart rate just now?
110.
That being said, there was a child crying when the heart rate was taken. Was it not temperature was afebrile? You cannot associate that with the heart rate. So really less than 2 seconds. Mucous membrane, no mention. Right? This is a case write-up, so be very sure what the hydration, what the markers of hydration status, and you need to mention. You need to mention capillary refill. You need to mention skin turgor. You need to mention mucous membrane. Right? Part of history is whether the child's thirsty or not. So clinically, is the child moderately dehydrated? Cannot say because not enough information. If the child is just tachycardic, but then heart rate is, but then capillary refill is less than 2 seconds, mucous membrane is wet, not thirsty, then the tachycardia might be because of something else, not because of dehydration, right? If the child has just slightly dry mucous membrane, everything else is normal, fine. You want to say normal to mild dehydration, fine. But there are no signs of moderate dehydration in this child, right? Apart from slightly reduced urine output in the history. But in your physical examination, either not enough information and whatever information they have doesn't really show dehydration. True or not?
Iza mentioned about the sunken eyes and also the reduced tears.
Reduced tears is during history, right? Sunken eyes.
Sunken eyes, I think during.
So based on assessment, no, isn't it?
Mention any sunken eyes?
The other thing about sunken eyes, you have to ask the mom whether the eyes are sunken or not also lah, because some people have deep set eyes, right? Just later on when you talk history, right? And then you think Not the mother offer. The mother offer that the eyes are sunken, then obviously the eyes are sunken based on history lah. But if you do physical examination and you think the child's eyes are sunken, right? But everything else don't tally, meaning the child is happy, running around, active, wet mucous membrane. You give him water, I'm not thirsty, I don't want to drink, right? Then you need to ask the mom whether their eyes memang like that or not, right? But if the mother offer that eyes are sunken, yes lah, then obviously you take it as true. What's the sunken eyes part? History or physical examination?
Sorry, when it is mentioned in the progression of what in day 1 when I take a look at the kesarap.
No, but based on your physical examination, isn't it? Hmm? Then if this is your summary should also include physical examination. On physical examination, there were no significant findings apart from whatever it is lah, right? The other thing, if the child is constipated, especially with girls, sometimes you were predisposed towards like having a UTI also lah. In an older child, not in somebody so young. Because there's backup of the urine, they don't want to pee so often. Next. So no mention of physical examination. Physical examination needs to be done as part of the summary, not just the history.
So next is the provisional diagnosis and differential diagnosis. The provisional diagnosis, it might be urinary tract infection. The points for are the fever, vomiting, poor oral intake, decreased urine output, transmitting urine, and the patient is also uncircumcised. The points against is no dysuria or urgency of forensic, although the patient is less than 2 years old. It's hard to ask about the history of that. And there were abdominal or suprapubic discomfort. But another differential that should be taught is actually the upper respiratory tract infection, which is the acute pharyngitis, as a patient can present with fever, vomiting, and the patient also has mildly injected pharynx and associated with poor oral intake. The points against is nose or throat, but again, it's
respiratory symptoms, right? Clear mucus and runny nose. Isn't that a respiratory symptom?
Yes.
And then mention something about no watery eyes. So I guess the person who clapped was trying to say that it's not allergic rhinitis. Allergic conjunctivitis is not part of it, isn't it? There were respiratory symptoms, right?
Yes.
Runny nose, right? Mucous membrane, right? Clear mucus discharge, right? That's a respiratory symptom, isn't it? And then the throat was injected, right?
Yes. So, should the provisional diagnosis be upper respiratory tract infection?
Isa, what do you think?
I think the provisional can be upper respiratory infection as it's more common than the urinary tract infection, but UTI should not be excluded for the provisionals.
Ulang balik ayat yang terakhir tu.
I think that the upper respiratory tract infection is the provisional diagnosis.
Probably UTI first, UTI later on. The other thing about UTI is that you need to ask whether there's a history of recurrent fever which is unexplained, right? The month for a few days, because usually if you get UTI in a young child, you are going to be worried about any congenital my brain's not working. Any congenital defects or not, right? like a posterior urethral valve, right? So those children usually they get recurrent episodes of UTI, right? So that's one of the things in history. If you really think if the child has UTI, you need to ask whether there was previously unexplained fevers, right? So those were UTI that possibly weren't detected. Or the child had fever, no runny nose, went to the doctor, doctor gave antibiotics, says sakit tekak, and the child got better. So maybe it was previously undetected UTI, right? So because usually if a young child gets UTI, then you're worried about congenital abnormalities like a posterior urethral valve, PUV. Okay. Okay. Some more. Dengue fever, fine. Fever, vomiting, child became less active. Basically fever, isn't it? None of this address the heart stools and the blood in the stools. Once again, history not enough lah. So history should have asked about the nature of the stools. How long has the child been having heart stools? Has it always been this blood? Has it always had this blood streak kind of thing, or is it a recent thing? Is it recurrent jelly or not? And then when you do physical examination, include looking at the perineum, looking at the anus, whether there's an anal fissure or abrasion or not, right? So not enough history, not enough physical examination in that part. No, because none up. Yeah, AGE, usually it's vomiting with diarrhea rather than just vomiting, right? Next. So investigations, the basic thing you always say is what? Nick, what's the basic thing you always say?
Full blood count.
So the URTI and UTI, that's the main differentials. So how would you investigate? Nick, differentials, the main one would be URTI, UTI, maybe dengue fever. So what's the main differentials you investigate? We should just ignore for the moment.
Sorry, doctor?
We should just ignore COVID for the moment.
Oh, ignore COVID. Okay. So for investigation, if URTI is the main complaint, then
URTI and UTI, isn't it? URTI, UTI, the other one will be possible at dengue, isn't it? Right? So what would you look at?
UTI, dengue. So I would send for the most simple investigation, which is full blood count, to look for the if for the dengue fever, we might look for the platelet level, also the hematocrit level, which yes, and if for the UTI or URTI, we look for the white blood cell count, which might be raised.
Dengue, what would you expect? Now will be day 4, day 5. What would you expect? What part of the MBC would you look at?
Day 4, day 5. Day 4, day 5. I will expect for because in the history there is no warning signs of dengue fever, so I would expect the hematocrit would be low and the platelet would be high.
Are you sure? Sophia, try. Sophia, cuba. IBC, if you think it's dengue now, day 4, day 5, what do you think?
Hematocrit will be high and the platelet will be low.
Yeah, the platelet will start to come down already, right? Also, the white blood cells will start to come down already by now. Hematocrit may be normal or maybe high, depending on the stage the child is at and whether the child is dehydrated also concomitantly dehydrated or not, right? So day 4, day 5, you already expect the white cells to start coming down, platelets to start coming down. Hematocrit may be normal, may be high, depending, right? So if it's URTI, most of URTI are caused by viruses. So white blood cells could be normal, could be on the lowish side, right? If it's a UTI are what? Bacteria. So Afika, what would you expect if it's a UTI? Fika, Nur Afika.
Yes, doctor. For full blood count.
Yes, if there's a UTI, urinary tract infection.
Leukocytosis.
Yeah, leukocytosis, so white blood cells will be high, mainly leukocytes, isn't it? Right? If the child dehydrated, also hematocrit may be high, but usually if the child not dehydrated, it might be normal, right? Yeah. Then what else would you do? Atika, what other investigations would you do?
Okay. For the other investigation, I would do renal profile, check for dehydration status. So basically, if the patient is dehydrated, the urine level could be high. So since the patient has episodes of vomiting, however, in the history we cannot we cannot quantify how many episodes, but still we have to check for sodium and also sodium basically and potassium to check if the patient has electrolyte imbalance due to vomiting.
Okay. And what in other investigations, Ridina?
Other than FCC, we can do ESR, because sedimentation rate, and also CRP. So to look for any evidence of inflammation and also infection. So if there is, then it might be high for both ESR as well as.
And yeah.
Sorry, doctor.
Okay, now ESR and CRP, right? In like an acute setting where you think it's an acute infection, it wouldn't be of much help. If it's high, so what? Right? If it's high, so what? It just tells you that there's an infection or an inflammation somewhere. Right? ESR and CRP is more useful for monitoring. So like Kawasaki disease, you track the ESR, right? SLE, you track the CRP a little bit, isn't it? Right? Or cases like prolonged fever, right? ESR and CRP might help you a little bit. It's like sky high, maybe it's an infection, but it still could be an inflammation. But maybe you treat with 1 week of antibiotics, repeat the ESR or the CRP, and it comes down, right? So most likely it's an infection because it got better after you treated with the course of antibiotics, right? So in cases where it's an acute problem like this, where you think it's an acute infection, but especially if acute infection, and ESR and CRP wouldn't be very helpful, right? URTI, dengue, you wouldn't think of it lah. Now your differentials are what? UTI, right? So what's the basic thing that you need to do?
Urine analysis.
Yeah, urine analysis and a urine culture.
Urine culture.
The other thing, urine culture, isn't it? And sensitivity before you start your antibiotics if you really think it's UTI, right? Because urine analysis, you can get back the results within half an hour, isn't it? Right? So you need to take both urine CNS and urine FEME. If the leukocytes pass, you see pus cells in the urine FME, then obviously you're going to start antibiotics because you think it's UTI, isn't it? Right? The other thing about the stools is that it's worth sending for what's the thing called already? Stool FME, and then see got worms or not. All right. For this patient lah, right? Because we didn't address the bloody stools. Okay. Now what else? Dengue. If you think it's dengue, obviously send all your serology lah. Whether you want to send a IgM, IgG, or day 4, day 5 can, right? If it's early on, then you send the NS1, right? Your RTI, nothing much. That's about it lah, right? Okay, anything want to ask not? Already 2 hours of me talking.
Doctor, I
Just
want to ask.
probably one only. Probably can get through one only.
Doctor, can I ask?
Ah,
I want to ask about the investigation for FBC for the dengue that you mentioned earlier in day 4 and day 5. Doctor, even though if in the history we got no warning signs of dengue, so we still expect it to be in we still expect the patient to be in the critical phase or still in the febrile phase, Doctor.
febrile phase or not, it depends on the clinical signs, isn't it? On the clinical condition of the patient, isn't it? If the child is still febrile, then it's still within the febrile phase. Isn't it?
Yes. So, Doctor, if even if in the day 4, day 5, still there is no warning signs. So, we do FBC, then we expect hematocrit to be low and the platelet to be high, or still, or the other way around, Doctor.
The hematocrit, the platelet will come down slowly one. It doesn't like now the child is in critical phase, then suddenly boom, the platelet will come down. No, it's a natural progression.
I see.
It's not that just because the child is in critical, you expect this to change straight away. No, it's not like a border where it's like now child febrile, now critical, straight away zoom, the platelet turun. Faham tak? It slowly goes down. Your platelet slowly go down. Your hematocrit will slowly go up.
Oh, go up. I see.
Faham tak? Sekejap
Faham, Doctor. I'm getting the point.
Sekejap.
Okay.
I cari untuk you ni. Izzah tak ni kan, tak share kan? Share ke tak? Tak kan? Okay. Izzah, stop sharing, Izzah. Nick, faham tak? It's a progression. Nampak tak? So your laboratory changes, your platelet will start coming down already. Day 3, day 4, tuk. Faham tak? Hematocrit, when you're critical, yes, the hematocrit will shoot up. That's why you need to know your baseline and don't let the hematocrit shoot up like that. That's why this is when you do your 4-hourly, 6-hourly FBC, isn't it? Right? So febrile phase, once the child is less than 38 degrees without the use of antipyretics, then that's when they start going into maybe the critical phase, right? But not all of them will. So your hematocrit will start going up. Here already, your platelet will start going down. It's not like the line is there straight away that normal macam tu tak ada. You already expect your platelet to come down. You already expect your white blood cells to come down, right? And then later on, your white blood cell will go up first before your platelet goes up. They don't put white blood cells here because usually you don't use your white blood cells to decide, right? But you use your platelet.
Yes.
Right?
Okay, understand it. Thank you, Doctor.
Okay. Any other questions not?
Doctor, for
Adik first.
Okay, for the physical examinations, such as cardiovascular exams, what would be the minimum age for us to be able to elicit any findings on the patient?
Sorry, I don't understand your question.
For example, like percussion for respiratory examination. How young can the patient be before S2?
Percussion, all ages can. You just need to percussion all. The only thing that's different will be chest expansion and vocal and diaphragmatic as well. No, that's the only thing that's different in physical examination for respiratory. In cardio also, the only difference would be the maneuvers, you know, when you want to accentuate the murmurs, right? But generally speaking, because in peds, you tend to get the congenital heart diseases. You don't usually get the valvular regurgitations unless it's the older age group, right? Because like rheumatic carditis, rheumatic heart disease, those usually affect the older age group, right? 10-year-old, 9-year-old, 8-year-old. So those ages you would have been able to do the maneuvers already, right? Breathe in, tahan, breathe out, tahan, see whether it's accentuated or not, right? But other than that, semua yang lain sama je. I saw one more question just now, somewhere. I don't know. It's already 4 o'clock.
And doctor, how in this patient, the full blood count result, it shows leukopenia, right? So how common is that when we, because usually
what's the white blood cell?
It's leukopenia.
I so know what's the white blood cell and what's the differentials. Leukopenia. What's the white blood cell? What's the differentials? What's the neutrophils? What's the lymphocytes?
It states white blood cells is low.
How low is low?
3.25, the value.
Okay, lymphocytes?
Lymphocyte normal, neutrophil normal. Both normal.
Platelet?
Both are normal.
Platelet?
Platelet not mentioned.
You cannot make an assumption based on one part of the results. Now, what causes leukopenia? Viral infection, true or not?
Yes.
Yes or no? Okay.
Yes.
URTI mainly caused by?
Bacterial infection.
URTI mainly causes
Virus infection.
Upper respiratory tract infection is mainly caused by bacteria or viruses?
Sorry, doctor, I can't hear you. The line's not clear.
Okay. Afika Tira, so upper respiratory tract infection is mainly caused by viruses or caused by bacteria? Even pneumonia is mainly caused by viruses or caused by bacteria?
Virus.
Huh?
Virus.
It's viruses, isn't it? What does viruses do to your white blood cell? What does viruses do to your white blood cell levels? What do you expect to see in viral infection?
Low in virus infection will be.
Does that answer your question?
Yes.
The assumption is now the assumption is if the platelet is normal, it's only URTI. If the white blood cell is low, I wouldn't be surprised lah, because most of the time URTI is caused by viruses. It's viral etiology. Viral fever would cause your white blood cell to go lower, isn't it? The same thing with dengue. What dengue is caused by a virus, right? That's why your blood cell goes lower, isn't it? All right. If the white blood cell is normal, HB is normal, platelet is normal, I can chalk it up to a viral fever. Then you observe and you trend it over the next few days. If the platelets will start dropping, right? Maybe and your first IgM and IgM serology, dengue serology is negative. Maybe do an NS1 instead. All right.
So if in the case of UTI, usually the what cell would be high, right?
Exactly. So can this be a UTI? Unlikely.
But then, doctor,
So
unlikely.
can
Or
unlikely, isn't it?
okay, understood. So that's why this case is unlikely to be UTI, apart from the history and then the presenting.
Yeah, but even the
feature.
presentation, there's upper respiratory tract symptoms, right? But the problem is the history is incomplete. And then, but investigation, because I didn't actually look at the investigations. Now, okay, if you guys need to watch how to do physical examination, then you guys can just when you're on YouTube, you can actually go here to watch. Okay, you can watch a few, not all, because these are for postgrads, but then some of them would be helpful for physical examination since you guys are at home anyway. So there's recipe, there is, because I'm sharing the whole screen. Okay, there's recipe, there's development, there's abdominal, there's neurological. The thing is, this is a postgrad website, so sometimes you see that they'll skip certain things, right? So make sure you read your books first before you watch, because sometimes you skip steps, right? They can skip steps because this is postgrad, right? They know what to look out for, but you guys can just take a look to familiarize yourself with it. Okay, since you don't get to go to the ward so often. Dah, took it down already now. Should I just click the link? Yeah, but this is on my playlist. Okay, so the link is there in the chat. Okay, so just write down the link and then you can just watch a few videos there whenever you have free time. Okay? Done? 4 hours and 5 minutes. Okay, enough. Okay? So no what work for 2 weeks, is it?
Yes.
You guys know what work for 2 weeks, is it? And then it get extended indefinitely lah. Okay. Anyway. Bye guys.
Thank you, Doctor.
Thank you, Doctor. Thank you very much.
Thank you, Doctor.
Thank you, Doctor.